Hello, everyone. It's your host again, Dr. John Lin from Sunrise Urology. I'm very excited to have in our studios today our guest, Dr. Vivek Malati. He's an anesthesiologist, the kind of people that surgeons love to hate, and we always blame anesthesiologists for delaying our cases. And I'm sure you guys have a lot of questions regarding what is an anesthesiologist, what do they do, and we're going to talk about passing gas, which is what they do. It's give you gas and kind of knock you out. So let me introduce you to Dr. Vivek Malati. He's a graduate of Baylor in 2008, right?
That's correct.
And then you went to University of Chicago and finished that in 2012.
Right. And then did a year of cardiac anesthesia fellowship in Houston at Texas Heart Institute, and then finished that in 2013.
So specialty in heart surgery.
You got it.
Anesthesia. Awesome. And also American Board of Anesthesiologists certified.
That's correct.
And you currently work with Chandler Anesthesia Consultants.
That's
right?
correct. Out here in Chandler, Arizona, as well as Gilbert, Arizona, and a few of the surrounding areas.
So you've been around the block a little bit.
Yeah, I've been here now for almost 5 years. 5 years. Yeah.
So what do you like the most about this field so far?
I enjoy the patient interaction. We get to meet quite a few people throughout the course of a day and a week, and everyone's from different backgrounds and different walks of life, and I enjoy that aspect of it as much as anything else. And I like the acute care nature of a lot of these things that we get to do, getting people under anesthesia, breathing for them, making sure that their heart and their lungs work well, and then waking them up and bringing them out. It's the process hasn't gotten old to me yet, so that's good.
Yeah, well, you're still a young pup.
I'm still as far as anesthesiologists go, still relatively young, though after a few call nights I've felt a lot older.
That's for sure. Now, for those who are watching this live, we encourage you to ask any questions in the comments, and we will try to answer them in the live event today, live show today. But if you're watching this on the replay, please feel free to leave the questions in the comments. Dr. Malati or myself will try to answer those questions for you if you have them. Just leave them in the comments. Now, there are anesthesiologists and then there are anesthesiologists. Recently, so first of all, what is an anesthesiologist? You guys pretty much alleviate pain, put people to sleep so they don't feel any discomfort during their surgery. It's interesting. Anesthesia is not really that old. It had its beginnings in the mid 1800s.
Right. We thankfully our techniques for what we use for medications, and not only medications but also monitoring patients while under anesthesia, have really markedly improved over the years, and it's made it a lot safer. It's made it a lot more effective too. And so I think now, if even looking at it from the way it was 30 years ago, it would be a dramatic difference.
No more ether.
Yeah, thankfully, yes. A lot of different gases that we used to use.
I was wondering how did someone come up with ether? This is crazy.
It's amazing. Some of the early on, some of the earliest anesthesiologists, the stuff that they were able to just kind of figure out that this is going to keep someone under and allow them to actually do some pretty barbaric things to them when you think about it from a surgical standpoint or from an injury standpoint. And thankfully those things have just evolved and gotten a lot easier to use and a lot more safe.
You bet. And now you guys use mostly sevoflurane, desflurane. Those are the type of gases that you guys use for anesthesia right now. But before we get too deep into the weeds, how does someone become an anesthesiologist? What does it require? I know four years of you get through undergrad,
right?
4 years of med school, and then
exactly.
How long is that training?
So after doing your med school, you would do a year of internship, and that can be in just internal medicine, it could be in surgery, it could be in a combination of both, which mine was, and then 3 years of actual anesthesia residency, and that can there's a number of different places throughout the country where you can do that residency. After that, many people elect to go straight into the workforce, as a number of my colleagues have done. Others would do a year of specialized training or a fellowship, and that can be within cardiac anesthesia, which is what I did, but there are fields like pediatric anesthesiology, pain medicine, critical care, regional medicine. There's a lot of different ways to go once you get if you decide to specialize. And then from there, generally speaking, people would go into the workforce and may may do only the thing that they specialized in, may rarely do the thing that they specialized in, which is something that kind of applies more to me, or a combination of both. So it just depends on the job situation that you get yourself into.
Sure, pediatric anesthesia, neurosurgery, and critical care are some of the other specialized fields that people can get into. Now, there are different kinds of where an anesthesiologist can work. I know you work mainly in the hospital and the surgery centers.
That's correct.
But anesthesiologists can also work in the office. Like
That's correct.
What we have here, we have an anesthesiologist come in to help us when we are doing certain procedures such as urolifts, or guys or gals who are very anxious with their procedures. So they actually come into the office and work as well.
Absolutely.
So let's talk about the different types of anesthetics.
Sure.
I know there's general anesthesia, regional anesthesia, and local anesthesia.
Exactly.
So let's talk about general anesthesia. What does that involve?
General anesthesia is more likely what people experience when they come to a hospital for an operation, undergoing any type of procedure. Essentially, it's a procedure where the patient is completely under anesthesia. It's they have no response to stimulation. In often cases, you're breathing for the patient, though in some cases the patient is breathing spontaneously on his or her own at that time. Those are the ones that I would say that you're at when people talk about going under anesthesia. That's generally speaking what they're having. They don't have any recall, more specifically, of anything that happens from the time that they are induced under anesthesia to the time that they wake up. That's the goal. With regional techniques, those are applicable. You see those mostly with a lot of orthopedic cases, knee surgeries, shoulder surgeries, foot surgeries, things of that sort. But they can be applicable to all sorts of things. And there are certain centers that really utilize regional anesthesia on a bigger basis, and that really involves using what we call local anesthetics, which are essentially numbing medications, for a lack of a better word. To numb down or remove the ability of your body to sense stimulation from different parts of your body. So for instance, if we were doing a knee surgery, I might do a peripheral nerve block that blocks the nerve that goes down to the knee. And so a surgeon could actually operate on that knee without the patient really being, feeling what's going on down there. And so the patient may just get some sedation in that case, just to help them relax while the surgery is going on. They may choose to go completely under anesthesia because they don't want to be aware of anything going on. So sometimes you can have a pure regional technique. You can have a mixed technique with it as well.
Sure, a regional and a general anesthetic.
Exactly. And local anesthesia is more along the lines of what might happen if if a surgeon was doing a case and wanted to inject his or her own numbing medicine or local anesthesia into the area that was being worked on. The anesthesiologist then would more than likely do what's called MAC anesthesia, which is essentially give medicines to keep them very sedated and comfortable, but not necessarily have them all the way under general anesthesia, not have them to the point where they're not responsive to any type of stimuli. In those cases, the patient may actually remember some things that go on during the procedure, or they may not. It just depends on the patient and how deep the anesthesiologist gets them under.
Yeah, MAC is monitor anesthetic care.
Exactly.
Yeah, or maybe with or without conscious sedation.
Sedation.
And local anesthesia is what I do when for instance, I performed 10 vasectomies in the office this afternoon, and I gave local anesthetic to the scrotal skin before I did the procedure. Now, I also provided nitrous oxide to 9 of the 10 patients this afternoon, and they did great. So that's an additional form of anesthetic,
exactly,
on top of the local anesthetic.
Yeah, and that's a gas that's utilized often by anesthesiologists, and it's often if you've ever had wisdom teeth pulled or a dental procedure of any type, there's a chance that they use nitrous oxide on you for that, to alleviate pain and also to give you some anesthesia as well. And patients generally tolerate it very well. There are some contraindications or things that you need to watch out for specifically when you use nitrous oxide, because it's not a completely benign drug, but in the overwhelming majority of cases, it's a wonderful gas to use for anesthesia.
Yeah, quick acting.
Exactly.
And patients, it works right away, and then it blows out of the patient right away, and they can get back to normal activity. As a matter of fact, within 10 minutes, they can drive themselves out of the office.
It's a quick onset and a quick offset type drug.
You bet. Now, people may ask, well, when does an anesthesiologist work? And part of the attraction for some of the anesthesiologists is that it is you don't have, there's really no, you know when you're on and when you're off, and when you're on call, you know when you're on, and then when you're off call, you're done.
Right. So and I would say that, you know, the job, the nice thing about anesthesia is really once you get out into the workforce, you can find a job that fits what you're looking for. If you're looking for a type of job where you know you're going to come in at 7 or 6:30 in the morning and leave at 3 o'clock, you can find that job. If you want a job where you might be on call quite a bit, or maybe just on the hook even when you're not really on call, that job exists as well. So I think you know, job flexibility is a really great thing within our field, and being able to find something that fits you and you know, fits the needs of yourself and your family is great.
Sure. Now, for those of you who are watching this live, please feel free to leave any questions in the comments. We'll try to answer them as we proceed. And if you're watching this on the replay, please feel free to leave any questions in the comments. Now, let's go on and talk about some of the newer advances in anesthesiologists. I remember during residency, when you have to put patients to sleep and put a breathing tube down them, sometimes it can be a struggle, and
yes,
it's hard to find the airway, the opening. And nowadays, there's something new that allows you to look down the throat in sometimes a narrow opening and find that opening so that you can put a tube down there to help patients breathe.
Absolutely. You know, when I was in training, the primary thing we used to use for what we thought were difficult airways, or airways that were going to be difficult to get that breathing tube down, was something called a fiber optic. And essentially, it was just that. It was a little camera at the end of a long piece of plastic, for a lack of better terms, that you would pass into the mouth, pass into the back of the throat, and then pass through the vocal cords into the trachea, or to the windpipe. And then we would pass the breathing tube over that. And that really helped a lot for difficult airways. Now we, you know, as the years went by, we've got, you know, even more advanced airway equipment, something called a video laryngoscope. And essentially that's a device that you can use to actually pass into the mouth. And rather than have to look into the mouth yourself, there's a little camera at the end of the scope that allows you to see it and allows you to make adjustments and get a breathing tube in a lot easier. And, you know, now in residencies, you know, residents are trained in that, or our trainees are trained in that very, very well, to the point where, you know, you'll see these types of scopes almost everywhere, and people are able to really use them effectively.
And I was in researching our interview today. I came across something called genetic determinants of post-op pain. Now, anesthesiologists are doing research on trying to figure out what are the genetic predispositions for certain people, and why some people experience more pain, and why some others don't. So those are some of the other exciting things
exactly
that are happening.
People who do pain on a full-time basis really look into a lot of that stuff, and it's amazing. You know, it seems like every couple of years we get new insights on what the causes of pain are and how to better treat it. So it's really great.
Now, some of the other things that you guys do, not only do you put people to sleep, make sure they don't feel anything, you also kind of keep the patients nice and warm.
Right.
And then I see you guys are always taking care of the patient's eyes.
Exactly.
During anesthesia. Can you tell us more about?
Sure. You know, the couple of things that happen once you induce anesthesia is it tends to dilate some of the blood vessels in your body. And as a result, patients can start to actually get a little bit cooler pretty soon, right after the induction of anesthesia. So a lot of times you will see in the operating room forced air warmers, or you know, devices that can circulate air around the patient. A lot of almost all anesthesiologists will use some sort of warm blanket around the head, even if they're not using a forced air warmer, to try to make sure that they preserve as much heat for these patients. Because not only is it the dilating of the vessels, it's that these operating rooms tend to be very cold in general. And so there's lots of reasons for the patients to start, getting cold or become hypothermic. And so we do a lot of different maneuvers to hopefully avoid that. As far as the tape in the eyes, we get a lot of questions from patients about that, because sometimes you can even see the outlines of the tape after the procedure is done.
On the
On the eyelids,
Yeah,
exactly. And essentially what that is that we're trying to prevent what we call corneal abrasions, or essentially scratches on the eye, because your lid reflexes tend to be abolished. If someone tried to stick you in the eye now with something, you being awake would be able to blink and hopefully protect your eye. You lose that reflex under anesthesia. And so to avoid any issues with possibly having a scratch in the eye, which can be very, very painful for a patient, almost sometimes more painful than the surgery they're undergoing themselves. We put tape over their eyes to make sure that they're covered and that they're protected. Sometimes anesthesiologists will put ointment in there as well to kind of add an extra layer of protection.
I've seen that, yeah.
And so there's a number of different things that people will do. And a lot of times patients, when they're waking up, the first thing they'll remember people, being yelled at is don't scratch your eyes, don't scratch your eyes. And that's really the primary reason we don't want them to get a corneal abrasion, because that can be something that lasts, for, a while after the procedure.
Yeah, because when you wake up, you're kind of disoriented.
Exactly.
Just
no different than when you wake up in the morning. You're awake, but not really all there, and it's not all that dissimilar when you wake up from anesthesia.
That's true. And the other thing that you guys do is protect the eyes. Is sometimes when I use lasers in the operating room, you put on glasses, just an additional. Even though you tape the eyelids closed, you put on eyeglasses to protect the patient's eyes from laser. And for sometimes when I used to use the shockwave lithotripsy machines that are a little bit loud, there are spark gap. It can be a little loud, so it's, your protection for the patient is something else the anesthesiologists also provide.
Yeah, the eye protection specifically for the lasers is something that's used quite frequently, depending on the procedure, obviously.
All right, so I am very excited. Let's talk about some of the questions that people have asked, such as malignant hyperthermia. One of the patients or one of the followers asked, "What is malignant hyperthermia, and how do we take care of that?"
Yeah, it's something that anesthesiologists really worry about a lot, and thankfully it's not. It's a relatively rare condition. Essentially, what it is if you've ever had a surgery, and an anesthesiologist has asked you, have you or anybody in your family had trouble with anesthesia in the past? They're trying to get at whether or not there's a possibility that you may have this issue. Essentially, it's a genetic condition which alters the way that the body processes calcium, essentially, and that alteration, or that defect genetically, can cause extreme muscle contraction that is difficult to control. And with that extreme muscle contraction comes a lot of different issues. A dangerous release of potassium into the blood, a dangerous release of acid into the blood, extremely high temperatures, becoming very hyperthermic. A lot of different things that can be deadly if not noticed immediately and treated appropriately. And so that's something that every anesthesiologist worries about. Thankfully, not all of us have had to deal with it. Myself, I have not in the 5 years I've been out here in Arizona, thankfully. But it's something that we always kind of have in the back of our mind and are ready to treat if necessary.
It's interesting that malignant hyperthermia was not recognized until 1960s. Yeah, some genetic predisposition to the phenomenon, and I have not seen in the thousands of surgeries that I've done. I have yet to see a patient suffer from malignant hyperthermia. And I was asking around some of your anesthesia colleagues; they have not seen it, but I know there's a special cart and stuffed medications such as dantrolene that we can provide and supportive care just in case something like that happens.
Absolutely.
Most commonly happens to men more than women, and 1 in 5,000 to maybe even 1 in 50,000 anesthetics given. But
it's so difficult to give a frequency because it's so rare, thankfully it's so rare. But as you said, almost every center that you work in, whether it be a surgery center or a hospital, will have an MH cart, a malignant hyperthermia cart, with all the materials that you need to treat whatever what's happening. Because again, it's deadly if not treated relatively quickly.
All right. Some of the other things that people have mentioned, anesthesia awareness. And I know you've been asked before you put a patient to sleep.
Absolutely.
They ask you, or they tell you, I want you to make sure you put me to sleep completely. I don't want to remember anything. I don't want to be awake. during anesthesia, but then you can't move.
Exactly.
So can you tell us a little bit more? How do you guys mitigate that?
Yeah, it's it's a good question, and it's the thing that I would say number one concern that patients have when they come to the operating room, and it's a scary thing. The idea that you may be undergoing a surgery and wake up in the middle of it and have someone operating on you while you're completely aware of everything going on. And so I completely understand the fears. And I believe there was a movie that came out earlier this decade that kind of spoke to that, and I think that's even kind of sparked some concerns among people that have either heard about that movie or saw it themselves. And what I would say to that is that's one of the few things I feel pretty confident telling a patient is that I can make sure that you're not going to remember anything from this procedure. And the reason I can say that pretty confidently is because of all the different medications that we have to make sure that a patient is adequately anesthetized and has amnesia for the appropriate amount of time. And all the monitors that we now have that we can utilize to look at all these things. Back in, way back when anesthesia was first in its infancy, we didn't have the variety of medications. More specifically, we didn't have the way to monitor them the way that we do now. And now we can see concentration of gases that we're giving to the patients very, very specifically. We can see blood pressures, we can see heart rates, we can see oxygenations, we can see all these things that can alert an anesthesiologist whether or not the patient needs more anesthesia or is at the adequate level of anesthetic. So I would say to anyone who's concerned about that, it's understandable why you would be concerned, but the risk of you having any type of issues with anesthetic recall under a general anesthetic, under your run-of-the-mill case, is extremely, extremely low. There's always that possibility of having something we discussed earlier, where you have a regional technique where not much anesthesia has been given to you, through an IV or through a breathing device, because you're not able to feel anything that they're doing on the part of the body that the surgeon is working on. But in your 99% of the cases that don't have any of that, or well over 99%, I should say, that possibility is extremely, extremely low.
I have yet to have one of my patients come back on post-op follow-up and tell me that they remembered anything, or they felt something during the operation. It's sensationalized in the movies, but it just does not happen in real life.
Thankfully.
Just like everything else. It's
exactly.
You see it in movies, and it's just simply not true. There's other things I want to kind of discuss, go over. The other benefit of just having the patient awake but anesthetized is when we do sling procedures, or let's see, C-sections, for instance. Right. You want the patient to be awake but then not feel anything going on down below.
Exactly.
So those will be the benefits of having anesthesia and being awake and aware of what's going on.
Absolutely. And C-section specifically, I can speak more to, just because we work quite a bit in our obstetrics department and labor and delivery. And the idea there is that for pregnant patients in particular, the incidence of having a difficult airway or having a difficulty getting a breathing tube in is a lot higher than in the general population, and that's for a number of different reasons.
Oh, no kidding! I didn't know.
Specific to the physiology of a pregnant person. And so for those patients, it's vital, or it's great when you're able to actually do what's called a regional technique, and we often do those under what's called spinal, which is essentially a one-time injection into the lower portion of your back that will make you more insensate or numb from around a little bit above your belly button down. Oftentimes you can use an epidural for the same way, and a lot of times patients who are in labor and get an epidural for labor then have to go for a C-section. We can utilize their epidural for the actual C-section as well. And all of this is to allow the patient to also be there and experience the birth of her child, but more specifically, it also is safer for the patient and safer for the baby as a result.
That's a great segue, because we can now talk about epidurals during labor. So what is an epidural, and how do you deliver the epidural to a pregnant, or actually imminent delivery woman?
So an epidural is just simply a way, when we speak about an epidural is actually refers to the space right outside the spinal cord. And when we're putting epidurals in a patient, we're actually putting a small catheter into that space. And that catheter is what delivers local anesthetic, or essentially numbing medicine, essentially into the area around the spinal cord, and it acts on those nerves that are leaving the spinal cord that go down to the rest of the body and down to the legs and into the belly as well. And it makes it such that the patient's brain cannot sense the pain that's coming from those areas. And so we can utilize that to really alleviate the discomfort that happens with labor, with contractions, both during labor, in the first stage of labor, which is as the baby is descending, also in the second stage of labor where the patient is actually actively pushing the baby out.
Okay, so when I know some people have said, well, sometimes it was too late for me to have an epidural during my labor. Can you tell us, when is it too late?
Realistically, in the true answer is that it's never too late. It really, from the time that you come into the hospital to the time that the baby is coming out, realistically, you could get an epidural. The issue often comes into play is that, particularly for patients who have had kids before, their labors can be very quick. And as the patient gets further and further into labor, having an epidural done for many people, for many anesthesiologists, requires the patient to sit up and to sit, still for at least a short period of time in order to get the catheter. And sometimes these epidurals can be done while the patient is lying down more in a lateral position, almost like you're watching TV on your couch. But I would say that the vast majority of anesthesiologists I know feel a lot more comfortable getting an epidural in while the patient is sitting up. And so at that point, once that patient is very far along, there's a very real chance that while trying to do the epidural, the patient may get to the point where they're ready to deliver. And so oftentimes, after a certain time period, or once a patient has progressed to a certain point, you may have, anesthesiologists who would say the risks of doing this right now are not quite as good as the benefit because the baby's about to come out. And so I'd say that's probably when you hear someone say they've kind of gotten a little too far along for the epidural, that's generally what they're referring to. But really, aside from that, there's not a time when the patient's in labor that you can't get an epidural in and can't get an epidural placed for pain relief.
Yeah, sounds great. Good information to have, because I know a lot of women are thinking, okay, well, I want to have an epidural, but someone has mentioned that it's too late sometimes to get the epidural. So it's good to get that get the straight answer from yeah. And the other thing that anesthesiologists do is pain management. Mm-hmm. Yeah, which is a specialized field, because sometimes men and women will suffer intractable pain, and I know anesthesiologists are very, very good in performing certain regional blocks and stuff like that in pain management. So that's we shouldn't forget about that specific specialty. Any new advances or any myths that you want to help bust?
No, I mean, going back to something we talked about with, epidurals earlier, I think there's a lot of, one of the concerns that patients often have is that if they get the epidural, it's going to increase the risk of getting a C-section as a result of it. And so, this has been looked at pretty extensively, over the years by some very smart people. And essentially what it's found is that getting an epidural does not increase your risk of getting a C-section. What actually, in fact, they think is the issue is that when you're having what we call dysfunctional labor, a labor that's going to make it very difficult for you to deliver, traditionally, and would require you to go to the operating room to have a C-section for it. That type of labor tends to cause the type of pain that patients often would have when they call for an epidural. So the patient may get an epidural because of the pain that they're having, but the epidural itself is not what's causing them to go to a C-section. It's the issue that's causing the pain is what's causing them to go to C-section. Yeah. So it's a bit of a chicken and egg type situation there. But I think if you're, for patients that are worried about that, I would say if you want to try to go unmedicated without any, without an epidural, without any IV medications, I say by all means, please do so. And that's great if you're able to do it. But if you do choose to get an epidural, or you just feel like you absolutely need it, I want to stress to them that they're not putting themselves at any increased risk for going for a C-section.
Yeah, as a matter of fact, American College of Obstetrics and Gynecology and then the Anesthesia Association came together and came out, did a massive study and came out with a consensus statement that, in fact, epidurals do not increase the risk of C-sections.
Right, right.
So that's from the gynecologists and the anesthesiologists in a very well studied and consensus statement.
And we try to make that as clear as possible whenever we get a chance, because the reality is that you can have those types of studies out, you can have these types of knowledge that's pretty well known, but the reality is people have friends that get an epidural and have horror stories, because they're not completely benign procedures, and I don't think we should ever tell people that they are that way. But if you have a friend that got an epidural and then went for C-section, it's very easy to think that one thing caused the other, and
Right.
it's not in real life, in the vast majority, these huge numbers of deliveries that we see, every year, that's just not the case.
I get it. And as I take a lot of patients to the operating room, one of the things that they always ask me is, I had a bad reaction to anesthesia and I was very nauseous afterwards.
Yeah.
Can you do something about it? So what do you guys do? I know for my patients that you have put to sleep, I have yet to have anyone tell me, oh, the post-op nausea, vomiting was terrible.
Yeah.
It's when they tell you guys, I know you guys put in some magic potions in there,
right.
before, during, and after, and my patients do great. So what do you guys do?
I would say, postoperative nausea and vomiting is one of the worst side effects of anesthesia. In many cases afterwards, your patients who really suffer from it say that it's worse than the pain of the procedure that they just had. So it's something that anesthesiologists really do take very seriously, particularly if a patient has had issues with it before. So there's a lot of different things that they can do. One is to utilize a combination of medications that work on different pathways in the body to try to attack the sensation of nausea coming, before it actually ever starts. So the hope is that you prophylactically can prevent the patients from having those symptoms. A lot of times patients can get a scopolamine patch, and patients utilize, those are actually sold to people really for motion sickness. But we have found that it works very effectively for preventing nausea after anesthesia as well. There are other things that we can do. We can try to use complete intravenous anesthesia versus actually giving anesthesia gases. That's thought to help with postoperative nausea afterwards.
So you think maybe the gases are emetogenic?
The gases can cause nausea, whereas some of the medications that we use through the IV can actually be not only are not causing it, but can have some anti-nausea effects as well. In certain patients, we'll try to minimize the amount of opiates or the amount of narcotics that we give those patients, because that can be nausea-inducing. So, depending on the patient, depending on the procedure, and the specifics of the situation, an anesthesiologist can tailor a plan to really do their absolute best to try to control the nausea. Now, despite all of that, despite best efforts in a lot of cases, patients do still feel nauseous afterwards. But I would say in the vast majority of cases, we're able to do something pretty effectively to help them out.
Sounds good. What are some of the other questions that people usually ask you right before they go under anesthesia?
Some people ask, is this like sleeping? Do I dream under anesthesia?
Oh, that's a great question.
And it's different. Some patients can report afterwards is that I had a great dream afterwards, and some people say I thought I was just sitting on the operating room table, and the next thing you know, I was waking up afterwards. So it's really, I think it's difficult to say. There's been a lot of research into kind of what, and the relationship between an anesthetic state and real sleep that you have at night. And there's just some really interesting, research that's always being done on it, and it varies. Studies vary on kind of how they perceive the two. But the best thing I can tell them is that I feel most comfortable saying is that for the vast majority of people, they will feel like the whole procedure lasted 2 seconds. They're going to be sitting on the bed talking to me, and the next thing you know, they're going to be waking up in recovery, wondering if the procedure's done or not. So that's something I feel pretty comfortable telling people afterwards. But the majority of people just want to know that you're going to be in there throughout, that you're going to be watching them, that you're going to take good care of them. Still, it still comes down to just good medical care. Being there for your patient, making sure that everything goes well, and providing reassurance that we do this all the time. It's a new experience for so many of these patients that come in. It could be their first, their second anesthetic, and it's very anxiety provoking. So really doing whatever you can to alleviate concerns and make sure that they know that they're going to get the best possible care that you can provide is probably the best thing that we can do as anesthesiologists.
I tell you, you guys have such a short amount of time between the time of surgery, time of meeting them, and then taking them to the operating room, and you guys all do a great job in instilling confidence into the patients that they're going to get great anesthetic care. And I tell all my patients who ask that the reason we as surgeons can perform these surgeries so safely is because of all the advances in anesthesia.
Absolutely.
Because you guys have done such a great job in keeping the patient still and monitoring the electrolyte and the fluid shifts, and to allow the surgeons to just concentrate on the surgery. Yeah. The other thing is I feel that we have great communication between myself and then your group and then yourself when we operate, because a lot of times I'll say, okay, 5 minutes and I should be finished. Yeah. And then you guys start doing your magic up at the head of the table and just slowly decreasing the anesthetic. So when I'm done with surgery, the patient's awake right away, and then we transfer the patient to the recovery room. They wake up right away, they go home, and they do great.
Absolutely. The whole idea with this is to give the patient as much anesthesia they need, but absolutely no more than they need or that they have to. And so, knowing when a patient is or a procedure is finishing, and good communication between an anesthesiologist and a surgeon is paramount for that to happen. These are all things that improve patient safety and improve patient outcomes as a result.
Sounds good. Is there anything else that you think we need to address and share with the audience?
I would say that the field has gotten safer and safer and safer as the years have gone by. And so if there's one thing I would tell people is that you'll be in good hands almost any place that you go for surgery nowadays. People are trained so well with our training programs and subspecialty training on top of it, and the techniques have gotten so much more advanced and have gotten so much cleaner as times went on. So if you're worried about having an anesthetic, if you're worried about having a surgery, just know that your anesthesiologist and everyone else that's involved with their care will do their absolute best to make sure that you do just fine.
Sounds good. Well, we have gone on long enough. I think we will conclude here. Thank you so much for coming on.
My pleasure.
If the viewing audience has any questions you want to ask, please put them in the comments as you're watching them on the replay. If there are any topics that you want me to cover, please let me know as well, and I will try to bring on guests that can address these issues for you. Feel free to share this video on your timeline so other people can benefit from this conversation. Thank you so much for watching, and thank you again, Dr. Malignant.
My pleasure. Thank you very much. Take care, John.
All right.